to get this meeting put together today, so we're extremely excited to be here. I wanted to talk about how we got here. Many of you all attended the meeting, I believe it was last May, in Winston-Salem, when Secretary Voss was supposed to be there. And it was not the most successful meeting, necessarily for Dave, his second or third day on the job. However, in thinking about this, I really feel like it was a very successful meeting, because what we got out of that was Dave's commitment to attend all the CFAC meetings across the state and really listen to our concerns. And that really impressed me. And I asked him when he came to Cardinal Inundation in July if he would be willing to come back after he visited everybody to kind of give us an update on what he heard and maybe the direction that the state is going to go. So he graciously agreed, and that's how we got here today. He is going to have to leave at 2:15, so when I talked to him a few weeks ago and asked if he would like questions ahead of time, he was like, no. So I believe the way we're going to do this is he's just going to maybe tell us what he heard. And then he's going to take questions from the floor. I would like to encourage you to keep your questions limited to maybe one so that we can get as many answered as possible. There are no cards if you have a question that maybe you're not comfortable asking or it doesn't get answered. If you just fill that out and drop it over at the table with Eric, there's a basket. We will get that to Dave, and I'm sure he'd be gracious to answer and get back to us. We have your email address, so we will be sending you out minutes from this meeting. Okay? So with that being said, I'd like to introduce Dave Richards. He's our Director of Mental Health, Developmental Disabilities, and Substance Abuse Services.
It was a successful meeting. So thanks a lot for inviting me back. I think I see a host of people I know, and many of you at that other meeting, and others weren't. So again, thanks a lot for the chance to come back, and I'll reiterate that visiting and spending time with CFACs and people that are part of our system through all sorts of stakeholder roles is something that is critical to this job, and I think for almost everybody in the administration in terms of how we want to do business. So I want to be clear about that and tell you that, again, this won't be the last, hopefully, that we do this, and it will continue to be an opportunity for a real exchange of information and dialogue. Let me mention a couple things. One, we are trying a lot of different ways to communicate. I don't know how many of you are tweeters or Twitter people. How many of you do tweet and Twitter? Well, 2 days ago, we tried to do a Twitter effort, and I saw some feedback from folks and saying, boy, that was a miserable failure. And I'm going to say that the truth is, a lot of it has to do with me and my ability to tweet. But what I will say is that no opportunity to spend time talking about the issues in any format, no matter how it appears, is a failure. And I think what I want to reiterate from our division, from the department, is that we're going to continue in every effort possible to have an open dialogue with folks in all sorts of different formats. Sometimes they'll be more successful than the others, and when they're not, what we'll do is we'll learn from them and we'll get better at the next time. And I think that's the message that we want to sort of get out, is that this is not everything we're doing is not a one-way street. It's absolutely the opportunity for us to continue to have these conversations going back and forth, and that's the important part. I want to start out with that first meeting. It was really probably the most important meeting that I've had since I started the past 7 months on the job. And it was important for a lot of reasons. One is that it was clear the passion and commitment people had about what does our system look like going forward, and there was not a lack of interest in what was going to happen. And that was absolutely something that I knew coming in from the role, but it was real clear at that point. It also was I don't say an eye-opener, but I think it was created clarity about the fact that people wanted to make sure that they had an investment in the system going forward, and that message was brought back to the Secretary. I need to mention that I've been going around the state, many of you in different forums and smaller groups that have the conversation, and that was the genesis of doing that at a much faster pace than what I had intended originally. And I think, in hindsight, the faster pace was the right answer to get out fast. So it was very important. At that meeting, there wasn't a lot of answers in terms of what our future system should look like and what it can look like, and there was good reason for that. And I'll tell you today, there'll be some. I'll be able to give you more detail about what we're looking at. But know that we're in an evolving process in terms of the partnership. So let me talk now about Medicaid reform, where we are, what we've heard from people across the state, what we've heard from you guys, and a little bit about the process going forward. And then I want to have a couple other quick plugs, and then we'll just open up for a lot of questions and dialogue, so we don't pull into that. Okay. Just in terms of process, so things you should know. The General Assembly, I think you probably all know this, but to reiterate, it decided that it would require us to come back to the General Assembly for any plan going forward. To create that process, they established a 5-person Medicaid Advisory Committee. I think that's the right word. They're using some initials that I'm not sure I'm going to follow well, but Medicaid Advisory Committee. That 5-person committee is charged with advising the department on the direction in terms of Medicaid reform. And the way you probably would guess this will work is that the department will have to come up with suggestions for this committee, and we'll have those suggestions going forward. They have to approve something before we bring that to the General Assembly. The committee was designed to be 2 people appointed from the General Assembly. Those 2 individuals are Senator Pate from the eastern part of the state, and Representative Dollar from Wake County. So I think you all, not all of you know them, but you probably know of them. Senator Pate maybe less, but he has been involved in our system a lot, so understands a lot about the mental health, PD, and substance abuse system. And obviously Representative Dollar, somebody who has a long-standing commitment to this system going forward. And then with 3 appointments that the governor had to make. And when I say this, I want to talk about a couple of things that I believe will, I think, are good indicators of the fact that people have been listening and the importance of our system to the governor and to the secretary. So the 3 people that the governor had the opportunity to appoint are, he could have chosen anybody. There was not there wasn't a preconceived notion of who they were, and frankly I just left my sheet about who they are, but I'll tell you 2 of them that I can remember the names. Thank you very much, you brought it. That's what I picked up. So the 3 people that he appointed, one is Richard Gilbert, who I don't know, but he's a doctor and an MBA, I think an anesthesiologist out of Charlotte. So a doctor, makes sense that you have appointment to that committee. The second is Dennis Berry, who chairs the committee. Dennis Berry was early on in the transition of the department, consulted with the department about issues around health care, but his history is he was the CEO of the Cone health system. So a very prominent role, obviously, in healthcare in North Carolina, so a hospital-based administrator. And then the third appointment is Peggy Terhune, who I think many of you probably know is the CEO of Monarch, which is a behavioral health, developmental disability, and substance abuse provider that has a statewide presence. I tell everybody this, is that, you know, Peggy is a very strong personality, and sometimes people love her, sometimes they're not as pleased with what she says, but what she is an outspoken individual and professional about our field and understands it very well. So what I ask people to think about is not so much who was appointed, but the fact that of the 3 appointments that the governor had, he chose to make sure one of those appointees was somebody who had a background in both mental health, PD, and substance abuse. I think that's the most important piece of that. Peggy understands our system. She will represent our system well in that advisory committee. And when you add the expertise that Representative Dollar has, and frankly Senator Pate, what I think you can be assured of is that in that advisory group, you have a group of folks that have great expertise around the issues that you care most about. So that's I think, an important signal about how people feel about our system. I also want to bring back another meeting that happened 3 weeks ago, and so when the governor asked to bring in healthcare experts around the Medicaid reform issue to the governor's mansion to talk about where we were headed. It was a relatively short meeting, an hour, with time for questions and comments. And again, in that meeting, I think you can take some comfort from who was invited. Of course, there were hospital administrators, there were doctors, there were association reps, but there was a commitment to our system. There were 5 people that were absolute representatives from the mental health and substance abuse system. One was Karen McLeod, who represents Benchmarks, a large provider association. The other, Bob Hedrick, another provider association. Lisa Wainwright, who represented the LME MCO interest there. And then Debbie Dehoff as the executive director of NAMI, and Lisa Petit, who is the interim director for the ARC in North Carolina. And again, what I want you to take away from that is not necessarily who the people were, but the number of people that were there representing the mental health, PD, and substance abuse community. And the goal was to make sure there was balanced representation, and that there, for the governor, and in that process where people had the opportunity to ask questions, that our system was fully represented. And I say that because then I want to go back to our first conversation about what was happening in Medicaid reform. I've said it pretty jokingly at other places, and I hope people don't take it out of context, but when the governor first announced this, and when the secretary first announced the Medicaid reform plan, I think you all know there was conversation about 3 CCEs, and that there was a desire to see competition, and that we would treat the whole person and go forward. And what came out of that press release, and I think the initial reaction was, we're privatizing Medicaid, and we're giving it all to a bunch of out-of-state managed care entities. And what wasn't said in any of those is that the other things that were said in that one press conference, and what was said right after that, is there will be an opportunity and an aggressive effort to get feedback from North Carolina, from every citizen in the state, from every organization in the state, anybody who has an interest, we will hear from and we will take into consideration before proposing the plan with a lot of detail. And when I went to the first meeting with the CFAC, that was sort of what we were saying, and rightfully so. I think everybody in the room was skeptical about that. And I don't blame you, and I think I said at the same time, I don't blame you for being skeptical. But what I want to convey to you today is that wasn't an idle promise. That was the commitment that everybody had made to this effort. So immediately following the announcement, there were an awful lot of what was a request for information. Many of you submitted that, many of your organizations did that. And then there were countless individual meetings that people dubbed as office hours at DMA. When I wind up coming on board in any meeting that involved our system, I was engaged in that meeting. And the Secretary sent me out on the tour of North Carolina and CFACs, along with a host of other organizations. I hear reported sometimes that there are, over 100 hours of people listening. Well, that's just a ridiculously low estimate. I think the number of hours is probably, well, I can't even come up with it. But I know for me, with CFACs and other meetings that we've had, I can guarantee you that our Division of Mental Health has done many weeks of meetings of listening to people about what the system should look like and what it should be. I told a story the other day about one of the meetings I attended in the with DMA and other representatives. And again, please, I say this, understand it's with great humility, is that I had a man who had been at one of the meetings, had heard folks say you should come, and he scheduled an office hour. And this guy was a really smart man, but he was clearly somebody who had never been in a meeting with what you would consider, high-level officials from the government. And it wasn't something he was comfortable with, wasn't a good public speaker, but he came in and he talked for an hour, and he talked from the heart. He didn't talk from a bunch of note cards, he didn't have anything. He would every now and then try to look at a piece of paper to do this. And in a room, I was there, and the head of the Medicaid was there, and another policy advisor for the governor was for the secretary was in the room. And what I can tell you is that his presentation and the power of what he brought was one of the most influential pieces of information we received. And I'm going to tell you this, it wasn't what he said. He was passionate about how he said it. And it was the idea that this guy drove, I think it was 3 hours away, drove to Raleigh. He got there an hour early. He said he sat out in his car trying to think about what he was going to say and how he was going to do it. And then sat in a room with a bunch of people who could easily be intimidating, I think, for folks, but got hurt. And I'm confident that he knew that he was hurt when he left, because the questions people asked were real questions. They weren't the typical questions that you get in some of these meetings. You know, you've always been in them, you know, the perfunctory stuff. But there were real questions about what it meant to his life, what it meant to his son's life, and how would this change make a difference, and how do we do that? Now, I say that because at the same time, you know, there were the big managed care companies that were in meetings, and there was the hospital association, and with the doctors, and every other big association was there. But the meetings that people were in went that kind of spectrum, from people with disabilities, family members, to folks that were really polished in how they presented, to people who weren't so polished, to people that just had scribbled notes on the back of the pad. And from all of that, it informed what we're doing and where we're headed. And I think the important part about this is that the commitment to listen and let that inform where we go was real, and it doesn't end today. And it doesn't end with the first meeting of the advisory committee. That there's an absolute 100% commitment that we will be in this together. So I've been saying to several of you, and in other places, there were 3 main themes I heard back from the CFAC visits and other stakeholder visits, and I'll kind of add a little bit more to that as we talk. But they were pretty clear. You guys, that first meeting, were pretty obvious and clear about, make sure that whatever you do, that people with disabilities, their families, and other stakeholders are absolutely involved from the first day to the last day throughout the system, and that doesn't change. So the idea that there has to be stakeholder engagement, involvement, and real meaningful stakeholder engagement, involvement can't be lost in any new system change. I've heard, people say, keep CFAC, and I'll tell you is that there may be another name, there may be something else, or it may be a different way, but the absolute message that has come has been loud and clear, it's heard, and it will be a part of whatever system looks like when we get out, that there will be active, engaged stakeholder involvement, which will have a heavy commitment to people with disabilities and families in that process. So that was one. And again, for the first day, y'all heard a lot about that. Secondly, and this is sort of I'm trying to synthesize this because the secretary would ask that I report to her when I come back from these meetings. And the second one was the idea that, this specialty system that we have right now, we get that you want to go into looking at the whole person, and that we don't want a siloed system going forward. And I'll say this, I was somewhat surprised at how many people said, absolutely, we're tired of silos. We want to see something that looks at us as a whole individual, looks at the loved one that way, and we need a system that goes. But there was clarity that we have a specialty system for a reason, that the medical model doesn't work in either mental health or in developmental disability or in substance abuse services, that there has to be heavy understanding of what those specialty services are, that they can't get lost in this shift in the system, and that integrated care doesn't mean having a medical doctor make a bunch of decisions and then ultimately consult with somebody else. What it means, real integrated care, and that you can't lose the integrity of that specialty system in whatever we do. So loud and clear, everybody hears that message we brought back and going forward. You'll see that, I think, in our plans. And then the third was, and it's said this way in a lot of different ways, is that we have a real fragile system. Providers are on edge, that we've driven many either out of business or to the brink of being out of business with our reform process. We have families and consumers on edge because the system changes all the time, and it's constantly evolving, and it's very hard to stay engaged in this. So it's a fragile system going forward. So whatever you do, don't destabilize it any further. You have to make sure, one, that transitions are done thoughtfully, that they're done reasonably, that we have a framework that we understand and exists, so that's how we heard it, is don't destabilize the system any further. And then a host of other things that came on. Obviously, outcomes that we were talking about from the very beginning, people were clear that, you know, we're tired of seeing the way we measure stuff by process. We have to measure around what are the real outcomes we want. And as you're talking about with those outcomes, don't go off on the side and decide by yourself if they are. Engage the community about the measures you have. So there was a real commitment to that effort. Certainly a lot of very specialty conversations about specific services and people with disabilities. So we're hearing those things. But what I want you to hear is that as we go forward, you'll see the components of those three big themes along the others in everything we propose. Well, here's where we are. If you've listened to the Oversight Committee meetings, or if you've been there, if you've heard from Bob Atlas or Marty Field, or Bob is a consultant that the department's using for this effort, Marty is a policy advisor that's tasked with leading this effort, you will hear them say, we are looking at three plans as we go forward. One, which will be around the general Medicaid population, probably the wrong way to say it, but that is sort of the side of the acute care side, the folks that are in Medicaid as their primary role, just as an insurance role. Two, around long-term care, and when we say that, understand that's really talking about the long-term care side for people who are older. It's more around the nursing home side of things and that effort. And then three, a special needs plan, that won't be the name of it, but a special needs plan that will encompass people with severe mental illness, those with intellectual and developmental disabilities, and a portion of those who have substance abuse disorders. How to define that's a little bit more difficult at this point as you're thinking about it. But those three plans will be distinct going forward, and that's the direction that we're headed. You'll also hear, and I hope you've, well, I suspect you all have heard because you're on CFACs and engaged, is that we as a department have been asking LME MCOs to consolidate to 4 regions. And those regions, when you begin looking at how we've begin talking about them with the LME MCO partners, look sort of a western region, a southern central region, a northern central region, and a eastern region. And you know, you can pull out your map, and it's pretty easy to figure out what that looks like going forward. We've asked the LME MCOs to commit to us by mid-December to that process. I think we're going to have that commitment there from them going forward. I want to tell you that's not because we just want to disrupt the system again and have people consolidate. That might seem like that, but that's not the reason. The reason for it is that as we think about this plan and this moving forward, a couple of things we believe are absolutely critical for services to people with mental illness, developmental disabilities, and substance abuse needs in a managed system is one, that there is a sustainable managed care model that works. And one of the keys to sustainability is that you have to be large enough to bear the risk. And that means that you have to have a large enough Medicaid population to bear that risk that will be required going forward. When you begin looking at that map, the numbers look remarkably close to a balanced system in terms of numbers. Medicaid eligibles tend to all be at 300,000 to a little bit above that, but all within a band. And you begin to look at more logical healthcare patterns about how people access other healthcare needs, and that is important as we evolve the system. So all of those things together are the sort of framework of where we're at today. Tomorrow at the Medicaid Reform Committee, there'll be a lot of discussion about what other states are doing, a lot of discussion about the things we're looking at in this broad framework, and a lot of comment and discussion amongst the committee. There will not be public comment tomorrow. At a next meeting, you can anticipate that will be a meeting with a lot of public comment, so be prepared for that. going forward. And then the following meeting, most likely in January, there will be a lot more detail on the plans. But what I'll say today is if you sort of listen to all of those things sort of wrapped around and begin to connect the dots, I think you get a sense that we are committed to doing what we said, building upon what works in North Carolina. There's an absolute commitment to the LME-MCO system, from the Secretary to everybody else that's working on this plan, and that there will be a major role for the LME-MCOs as we go forward. And that is in response to what you guys have said. It will be a system that still will be engaged around the whole person. It will not be a system that is siloed. And we expect that there will be absolute critical engagement from families, consumers, providers in the process going forward. And that commitment won't wane as we go ahead. Frankly, your responsibility, I think that's the way we ought to put it, is that you don't disengage now. That you follow this advisory committee, but honestly, we will most likely, you would assume, figure out a way to have them support something that we propose going forward. So there will be something coming out of it they'll support to go forward, and then there'll be a legislative process. You have said loudly and clearly to us what you believe, and I think it's really important that you keep saying that to us in the public forums, but also to members of the General Assembly as they begin to talk about what this system looks like going forward. So, although I think, and I'll say I'm very proud of the leadership at the department for their commitment and the governor's commitment to our process in gathering that information, but now is sort of the actually the beginning of the sprint, not the end of it. And that's when the engagement needs to be really heavy. So I'd say after the first of the year, you ought to be absolutely committed to your advocacy work through CFACs or other organizations you're engaged with in making sure that the system that ultimately comes out of the legislative process is one that you feel comfortable with and you feel good about the design going forward. We will continue to, again, commit to Medicaid predictability, because we have to have that as we're going forward, and treating the whole person rather than a siloed approach, and again, meeting those principles that I talked about just a minute ago. I probably ought to stop and see if questions, anything else, and I can talk forever, but why don't we stop and just start seeing what questions, comments people have about that.
Okay, for questions, Anna Cunningham and I will move around the room.
See, I was afraid you were giving a microphone to Anna, and it scared the heck out of me.
She's not going to be talking at it most of the time. She's got to let other people talk. So please raise your hands and we'll move toward you for the questions.
You probably already know what I'm going to ask. But
Yes, there will be.
well, folks in mental health think that the system is operating with crisis services, and these are very expensive. So we think that it would be better to support people in the community, help them not need crisis services. Do you have a plan for that, or how is that going forward?
Mark, I was in trying to preserve time. I didn't go into the crisis initiative that was brought, but I think it's a great time to just bring this up. Is that what I've talked about now are sort of the big, highest levels about how system design works. What we know, what we've also heard and what I understand is that one is that anything we do around mental health and substance abuse has to be recovery oriented. We cannot continue to rely upon the high-cost, expensive services like emergency departments as our primary way of supporting people. We have to support people before they go into crisis. If there is a crisis, we have to make sure that the system that they come home to is one that works and is responsive on a daily basis, and that we have to align our resources to do that. We are, on our crisis effort, I'm excited about the little things that we'll be able to do early on. And when I think of little things, I think we'll have an opportunity to work on pilots with LME-MCO partners, with some of our consumer organizations and other providers around the state to enhance the things that we know that work. And I tell Mark this, it's not blowing smoke because he's in the room, but Mark and Lori Covey and others have taught me an enormous amount about mental health services in a very short period of time. Those of you who know me know that I had no clue, obviously. I wasn't something that, I said this before, I probably should never say that when there's a camera in the room. Don't cut that just to say that he has no clue, right? But really didn't understand often what mental health advocates were saying when I was working with the ARC because it wasn't our focus. But it's clear that we have to have a system that meets people where they are, that supports people in recovery, that provides a lot of low-intensity services to avoid the need for the highest services. And we're committed to that now, but most importantly, in the future of this system, that has to be built upon that. So there will be a system that's built on those principles.
Thank you.
And thanks for always being here to say that.
Hi, my name's Lori Ireland, and I am the parent of an adult son with a developmental disability. I want to start out by saying that often I sound caustic, and I don't want anyone here to feel as if I'm attacking them. Certainly not Dave, not Cardinal Innovations waiver, because as I think Dave pointed out, this is the voters of the state of North Carolina. I think that we need to really focus on that. It is not these people trying to limit our services. It is the state of North Carolina. And the voters in the state of North Carolina basically have voted saying this is not a population cohort that they care much about. And I'm not overly politicizing it. I've lived here 20 years, and in the last year I have traveled around the United States in a program that I'm involved with, Autism Speaks. And 20 years ago, this was considered a wonderful place for people with developmental disabilities. Now the other states are appalled at the conditions and the way that the people are treated here, and a lot of the rules and regulations. And these are the same people that access Medicaid, they just do it differently in their states. And I'm going to say so. My questions have to do with, again, this is the state and it's of the voters. It's not Dave, it's not Cardinal Innovations waivers. But first of all, I wanted to ask about the onerous amount of paperwork. I've seen over my son, he's 23 years old, and now his people that work with him and the amount of bureaucracy between him and the state is absolutely unconscionable. We spend, as a population, a lot of money on the people in between. We're not providing any more money for the population themselves. We are not allowing any new people into the mix in terms of DD anyway. But yet, I have to attend meetings and sign papers, and people who work at not a high wage with my son have on their own time to fill out every little box and corner, or else the services are taken away. If I want to take my son to the county fair, he has to go through paperwork because he's not going to be going to work that day. He has to get, and excuse me again, I'm not a professional, so I don't know the nomenclature as well as you all, or the actual acronyms, but you have to go through a huge bureaucratic thing just to take your person out of work for the day to go to the county fair. That's got to change. That is a huge, big deal.
I'm ready to respond, Lori. I'm here.
And I know you are. Transparency. The whole idea that we were told that they were going to come up with this new thing called the SIS, but it was not going to be used. It was never going to be used. It was not going to be used to determine services. That obviously was not true. And that's what we were told. Specifically told that. My son was SIS'd 3 times already. Supported employment. I think that this is a very big deal for Extraordinary Ventures here, the building you're in, and the people that we try to serve. And the rules and regulations make it extremely difficult for anybody to work at all. Between the federal government rules about which you can't touch, which have to do with their disability income, but also how inclusive an environment has to be for everyone and how that's determined. I think that all the rules are stacked against a person working if they have a developmental disability. Okay? So I'd like you to respond to that. And the other main thing is, when you talk about the mental health substance abuse model, I think a lot of the model that's being used is splashed over into DD, where it is not relevant. You cannot show every month an improvement. You cannot show that the person is moving toward a cure. They're not. They're never going to be cured in many cases, and therefore the way the paperwork is written, in order to retain your services, you have to play this game. And that it's a waste of a lot of people's time. My son is mentally retarded and has autism. He's always going to be mentally retarded and have autism. He's always going to need services. That's just the way it is. So, those are some of the main things, and I've got a lot other, as Dave knows. And again, I am not attacking anyone here. It is the voters of the state of North Carolina. Even if your Cardinal Innovations waiver person comes to you and says, you lose this service because of X, Y, Z, that is not Cardinal Innovations. That is the rules that the state of North Carolina has put in. Wait, one last thing, sorry. My understanding from elected representatives is that, for instance, Cardinal Innovations waiver is under a lot of pressure to save money in some areas so they can use it for other areas, in particular psychiatry, which is I guess, at a crisis now. No psychiatrist will work with reimbursement rates. So they're trying to save money in other areas, but I sure hope that doesn't mean we're robbing Peter to pay Paul, because none of the community is being served properly. So to try to save money on one group, I worry about those things as we move forward.
Okay, so I'm going to try, Lori, to get all of those. It's great to see you again. I didn't expect that question. This does relate to long-term to Medicaid reform, but it relates to short-term issues. And I'll tell you what I've and what we have begun the conversation internally about, and will begin to have a much broader conversation with the community. I came from the developmental background, and one of my frustrations with this system has been that we have a outrageously regulated waiver, DD waiver, that has just extraordinarily complex, difficult to deal with service definitions to provide what should be support services in a community setting. We claim we value self-direction, but we do everything in the world to avoid it by creating more complexity for people trying to use that. Resource allocation, I happen to believe that resource allocation makes a lot of sense, but you don't do resource allocation unless you exchange it for a much more flexible waiver. Part of the principles behind resource allocation always were a self-directed approach, and that was that if you had the flexibility to do more things within that waiver without the burdensomeness of the rules and regulations, resource allocation essentially caps you, so you reduce the potential for misuse of the service. We've done none of that in the current managed care environment. And that is not blaming anybody, that is just the reality of where we are. I believe that as we go forward, and in the short term and the long term, it's both short and long term, we have to re-examine the principles upon which we do home and community-based services for people with developmental disabilities. And that is that we have to have a much more flexible system that supports self-direction, supports habilitative services, and avoids the, as you described, the regulatory malaise that we're in. And frankly, that should be across the board in everything we do. Our regulatory system, let me take one step back. There's an awful lot of conversation, how much you guys get into about this gold star monitoring thing out there, and whether we're going to keep it or not keep it. And what I've been saying to people, and I think it's what we have to do, it has nothing to do with gold star monitoring. This has to do with significant regulatory reform about how we look at our system. The way we monitor it today is based upon a 1960s model. It was based upon licensed facilities. In fact, actually, a facility in some ways is defined as an individual service in the state, and that is based upon, again, antiquated service delivery models, service delivery expectations, and frankly doesn't recognize technology changes or anything else that's going on in the system. So all I have to say is I couldn't agree more with what you said about the regulations and how we do business and what we have to change to move forward. I also agree, in the employment side, I believe absolutely that every person who has a disability, who wants to work, who has the opportunity to work, we should just do anything possible to make sure that individuals have a job. But I've also said a couple of times that I do not want to be the director of the division that sends a bunch of people home because we've made a commitment to one model of supported employment and haven't looked at the unintended consequences of what that means. And I think that's part of what you're describing in terms of what does integration mean and what does community integration mean. We have to examine that based upon what individuals' needs are and what our system can absorb in a transition period. So we have to be common sense approach about how we do those things. And we have to look at what our system design is based upon what 2013 and 14 looks like, not what 1975 looks like. One comment about the overarching political side that you did. Clearly, people will agree or disagree with the direction that the General Assembly or the administration takes upon the big philosophical questions of our time, right? And that is absolutely everybody's right to do that, and you should participate in the democracy in the way that you believe you should. Mental health, developmental disability, and substance abuse services should not be a partisan issue. I will say to you is that the governor is absolutely committed to mental health and substance abuse services. He doesn't bring up developmental disability, mainly because I don't think it gets lost in the nomenclature right now, just like a lot of people do. But it is a high priority, this system for him. Secretary Bosch, every day that we meet, talks about this system and about what should happen and how do we make sure it's accountable, how do we get the right services going forward. And then when she talks about developmental disabilities, she makes that distinction and understands the differences about the service that we should. So I want to be clear is that as you think about your big political stuff, that's one side, please be engaged in that process. But I would beg you not to politicize this system, because if you do, we'll all lose in an effort. It's about what's best for citizens, and we'll get there if we're all on the same page. And I say that with all due respect to Lord, because I know how strong advocacy and position that she has and how she's engaged in many things. This engagement is what we need, because we need to create a system that works regardless of who is in the governor's mansion or who controls the General Assembly. And that's what the goal is for what we're doing in the department right now. I think I answered most of the questions. It was hard.
My question is for developmental disabilities in these Johnston County Industrial Training Center in Smithfield. They've got all these consumers. They don't have a support system, and a lot of them, they contact me, which I'm a certified peer support specialist. I'm one of 7 in Johnston County. But, you know, we've got to reach these people, because if we don't, they're going to fall through cracks. They're going to wind up in the jails and other places where they don't want to be. So there needs to be help.
I appreciate what you said. I know we've had conversations in a couple other forums, and a couple things. One is that in the media, part of the reason why the focus on this crisis initiative, and let me be clear, I think many of you know we've had a lot of work done on crisis over the years. There are a lot of great things going around in the state. There are a lot of good things that are happening in a lot of communities. The purpose of this is to focus and get energy and momentum around the services that people will need, and those will be those services that are directly in the community to help people avoid having to go in crisis. Because we know if we're not supporting people at the right level in community now, then we exacerbate the crisis issue, and we never get to the solution, which is to support people before they get there. So we're committed to doing that.
Okay, Dave, this is questions that were given anonymously, and I'm going to run through them. Basically, what is going to happen with Medicaid insurance with Medicare since the state decides not to go with the Affordable Care Act? How will this affect people with MHSABD issues? The next one, have seen changes happening already with Medicaid. Consumers can only cannot receive eyeglasses and certain procedures at the dentist. Will this change in the future? And have seen where people with food stamps have been cut off or cut down. Is food stamps not going to exist in the future? And how bad will the change cost consumer services? Do we have any answers?
So on the Medicaid expansion, clearly I can't and won't discuss that in terms of whether or not the state will do it. You guys you've read, you've seen what people say about that. That is not part of the equation in terms of we're thinking about the system design going forward with Medicaid reform. Now, obviously, it's an issue that people need to talk about it, but I can't respond to that. The questions around the other cuts that taken in Medicaid, those are General Assembly efforts to control costs in a fee-for-service world, and that's why you see some of the optional service reductions, and that's what those are. I would say that one of the goals of the whole Medicaid reform package is to make sure that we have predictability going forward, and that opens up the door for a different discussion about expansion and those kinds of optional services going forward. What everybody should know is that at the end of last year, the General Assembly was asked to put $500 million more state dollars, and that's really important to know, $500 million more state dollars to cover a Medicaid hole at the end of the budget process. Now, it happens almost every year that that's going on. I don't think there's regardless of what political party or what political beliefs you have, I think most people understand you can't sustain a system when you have to do that. And part of that is because in an entitlement program, you have no way of often controlling those costs. The option the General Assembly would look at would be to eliminate optional services altogether. Now, that's a very hard thing to do because then they take away whole programs from people, and I don't think anybody wants to see that. But the reason why you see some of those things happen with dental and eyeglasses is because we've been chipping away at some of those optional programs, and that has nothing to do with this mental health, substance abuse proposal, but it has everything to do with the reason why I think people believe there has to be Medicaid reform. And I forgot what the last question was.
The last question has to do with how
Food
bad.
stamps. You know, there were a couple things that happened, and this is not my area of expertise, but I'll say, you know, there are a lot of concerns about the transition to the FAST system. I think mostly those have been resolved. There were local county social services issues as we did that. And then there has been, though, a reduction in the amount of money, I think, that people get food stamps, but that was a federal reduction. It wasn't a state reduction that came through. So in terms of the future of the food stamp program and those others, I would not know, but I don't think that it is on the table to eliminate anything, and I don't believe there's been much conversation about that, either at the federal level, clearly not at the state level.
Hi, Lola Fisher from Alliance in Cumberland County. My question to you is that IDD, they're cutting programs. One of them is community networking. It's supposed to be a short-term program. IDD does not get better. So when you cut that, what has been suggested through the care coordinator was put them in a day program. How is a day program not segregation but integration? Because every day program I've seen, they're segregated. And I do not believe that our IDD population needs the segregation. They need to be in the community. A lot of them have their own CAP worker, innovations workers, and that way they are seen, they are accepted. I've seen in the past 20 years I've been in this field, much more acceptance when you get them out in the community. And the only way to get a large group out in the community is with a one-on-one worker. When you cut those one-on-one workers, you're putting them back upstairs, hidden away in the closet.
So, this kind of ties back a little bit to Lori's point in the question about how MCOs are managing dollars. In the current system, it's a 1915 BC waiver. That's the technical terms of it. And so in the broader scope, you think about this, B is primarily the mental health and with limited substance abuse services. It also includes ICF or ED. C is entirely the home and community-based waiver, which is the innovations, formerly CAP waiver. They are, although managed in a managed environment, they are separate funding streams. And the management that the LME MCO has to do for the C waiver is to manage it separately in terms of how dollars are allocated. One of the misunderstandings, let's use it that way, misunderstandings that happened as the BC waiver was passed through the General Assembly was that somehow there would be an expansion of C waiver slots through some managed approach. There have been limited increases in that, and those have been planned waiver increases to begin with. The BC managed care waiver doesn't contemplate increased slots in its current form. The only way any significant change will happen in that is if the General Assembly appropriates more money for the C waiver side of this. So I say this, and this is why I want to get to the longer point of this. I don't believe, and we said this in the original meeting, I don't believe that the BC waiver in its current form would be sustainable no matter what we did, because there are structural flaws in the way we fund it long term if you're going to meet the needs of North Carolina the way it was currently designed. Again, not saying something wrong about the people who did it, nothing wrong about the legislature who did it, but long term it doesn't offer the opportunity for expansion without significant increases in funding that goes into those into that effort. There are some things we can do immediately to try to help serve more people, and we'll be working on those in the first quarter of the new year that we think might gain some traction to serve some people. And we have the LME partners and consumers and families and providers. But probably the best hope for long-term sustainability is a new system, one in which we can begin to look at the entire Medicaid dollar that goes to support somebody, not just the long-term care money, which is in the C waiver. So medical money, all the other money that's tied to that, and frankly realigning the incentives that we have for how people get supported. I will say this, and this will be, I think it's one of those discussions we have to have, and we have to have a lot of real detailed conversations with families and consumers and providers. Creating services that only rely upon a one-on-one worker with somebody 24 hours a day is not sustainable. We have to look at other options to be able to support people. And that's not to say we should be requiring and doing individual supports in the best way possible, but we have to look at technology answers. We have to look at other ways in which people can be engaged. Again, I think we have to offer a lot more flexibility in how that waiver is used, rather the numerous discrete service definitions we have. There are lots of opportunities we have to change the way the system design works, but that requires us to have real difficult, honest conversations about what the future of the system looks like, and we will be engaging in that. But I would say that we're probably going to wait until after the first of the year, and it'll happen in that first quarter.
Hi, my name is Marcus Matthews, and I have a few questions about things that's going on. One of them is that Medicaid, Obamacare, I call it, why the governor and his people want to get rid of it. The second one is, what are the costs of everything going up? Are y'all trying to make us pay for debt that y'all say North Carolina is in? And the third one is...
Can you repeat that one more time, that part?
Why is the cost of everything going up? Are y'all trying to raise the cost on things so we can pay for the debt that you say North Carolina is in? And the last one is, you say you're trying to help us, but I hear that the governor and people are saying on news and everything, they're going to help the Republicans and the ones that are rich get richer. We're still staying poor and still struggling to get by. So I just want to know what you're planning on doing for us as middle class is already struggling.
So I should have said it in the front, is that there are several questions that I could not answer because they are at a higher pay grade. Let's do that. At the governor's level, that'd be different. But I do feel compelled to defend a few things because I think there's an awful lot of misunderstanding about what people are saying. One is that The governor did not deny the Affordable Care Act. All that the General Assembly did and the governor did is choose not to expand Medicaid under the terms that were put in place in the Affordable Care Act. Now, that's a big issue on both sides on how people think about it. The governor said, and I think there was a great deal of accuracy to what he said, is that expanding Medicaid in a system that you cannot control and monitor costs is a dangerous road to go down. So you'll hear him, and you've heard him say Medicaid was broken, and until we fixed it, we really could not, he didn't feel comfortable with the expansion of Medicaid. I think that's still the position that's there, is that until we have a plan going forward that deals with Medicaid reform that is sustainable, that allows for the treatment of the whole person and is outcome-based, he doesn't believe, I'm not speaking for him, but I'd say this is the words I've heard, that it makes sense to try to do the expansion at that time. Now, again, that's a different political question. Everybody has the right to discuss that and debate that way you want to. But that's the position the state has taken, and that's where we are. I don't think there's any, has been any attack on middle class. It's certainly not in the Department of Health and Human Services, and I can clearly tell you that there is nothing in this reform effort or in the things that we're trying to do in the mental health and substance abuse system that is attempting to raise prices or costs or services to anybody. It's actually an attempt to make sure that we have a system that can be sustainable going long term, and that's what the goal is. So, although I understand people being frustrated, I do hope folks will begin to pay attention to what happens, not just what's reported in the media, because I think often those things don't necessarily line up. John?
In the terms of crisis services, as everybody knows, there's a great lack of beds in the state hospital system. In Durham County anyhow, and probably in some other counties, there are things like Durham Center Access where people can be kept on 24-hour beds for several days to help prevent them from going into the serious crisis where they would need state hospital beds. Because of the lack of beds available, there are people kept in EDs for weeks at a time, apparently, and they can't be discharged to centers such as Durham Center Access because that's a lower level of care. Is there any thought for how to get that lower level and lower cost of crisis care at the county levels or MCO levels in order to prevent this great lack of beds in the state system?
I think what you're describing is exactly what we're trying to achieve with the crisis effort that we're doing. There's no one answer, all right? And so about hospital beds. We created 3 new state hospitals. We reduced the number of beds as we did that at the beginning of mental health reform. We reduced the number of hospital beds. There are a host of different studies you can look at of what's the right number of hospital beds per 100,000 that are out there. I happen to believe that we're much better off having community hospital beds rather than having more state hospital beds, because I think that allows for us to have them in places closer to where people live rather than in these regional-based centers. Now, there's a need for those regional-based centers. There's probably a good debate you could go on as to what's the right number there. But I'd rather see us try to expand that access into community beds versus the state hospital first. The General Assembly has recognized that need by appropriating more money for something we call 3-way hospital beds, which is a contract between us, the LME MCO, and the hospital to make sure that people who don't have insurance have access to those community beds. I think it's been very successful, and the expansion has, I think it's $8 million or $9 million additional dollars this past legislative session, and I think there's a willingness for them to continue to look at expanding that as long as they see that that's going into the right place. But it's only part of the solution. Mark and others and lots of folks will say exactly what you do. If we don't have the right community-based solutions, then we're going to have more people in those hospital beds. So our job is to, one, is to make sure that that's available, because that's a need right now. We don't need people sitting in emergency departments, and we have to attack it at that level. But at the same time, we have to adjust our system to begin to create that more robust community-based system that relies upon those recovery-based services, more informal services sometimes, but most importantly, the services that keep people out of crisis. And look at some other options for community-based services that might be a higher level than those low-intensity services. What I don't think we should do, this last point, what I don't think we should do is to try to aggressively build up the highest services right now without looking at the mix of those community services, because I think we'll overbuild, we'll make mistakes, and that isn't the best answer.
Dave, how are you?
Matt, how the heck are you? You were at that first meeting too.
Yeah, I'm everywhere. You've got to stop being like this. Well, a lot of what I was going to say was already said by Lori, so thanks for that. But you can mark your calendar right now, Dave, because I'm going to give you and the governor's office a little gold star, a little pat on the back, because I wanted to say that I personally am really glad to see that there are discussions and movements being made with regards to the Medicaid buy-in and allowing for more flexibility for incomes, especially with people within these populations. The only thing that I would add to that is that I hope that discussions continue as far as how to expand that flexibility further in the new system, because you talked about employment and how important that is, and that's very true, and that's all well and good. But the way that the current system works, a lot of the time people do get jobs, but they're the kind of jobs that people get just to say they have a job. And obviously there are certain people with certain types of disabilities that work fine in that environment where it's very structured, and they only need certain things, and they don't necessarily want to move up the ladder, so to speak, or however you want to put it. And for them, that's all well and good. But I know many individuals from around the state, myself included, though I'm not as far into it as they are. I know many individuals around the state who struggle to remain employed and earn income that they deserve while maintaining their services. And frankly, if a system can get worked out that's more flexible and more stable for those people, and that allows them to maintain their services, everybody wins, even the people that have literally nothing to do with this. Because the more people that you have employed, and the more people that you have actually making competitive wages, or maybe even better than that, the more money that the government is getting back in the form of taxes. So, frankly, like I said, pat on the back with regards to the Medicaid buy-in and all that sort of thing. That's great. That's a step in the right direction. But I hope that discussions continue on how we can get out of this idea that if someone is making money, then they don't need the support, because especially with something like personal care, right now Medicaid is really the only way to get that support without having to pay for it out of pocket, which is ridiculously expensive. So, to sum it up, good job on that part, but keep the discussions going on that, because it might seem like an impossible thing to figure out, but I really don't think it is. I really think that it's a type of situation where if we can just step back and realize how crazy the current system is, then maybe we can figure out something better more easily than we realize right now.
Appreciate that. Great. You know, one of the things that, first of all, Matthew is in all the right places, and it seems to be every place I go he is. So that's, I don't know if it's all the right places, I may be all the wrong places, I don't know. But what I want to take away from what you said, and it's clearly we have to do work on employment, and I will tell you is that there is a strong commitment around employment issues in the department, and there is a beginning stages of a cross-departmental effort around all of our employment programs. So, you know, in the DHHS, we do employment in almost every division is some stake in employment. But the truth is we don't spend a lot of time talking about that together or thinking about how to coordinate our efforts on that, which is really a shame in terms of how we spend taxpayer dollars. So that process is beginning, and I think you'll see much more bold efforts on the department's effort around work in the coming year, which I think you'll be happy with on that. Everybody should be happy about that. But what I will take away, the other thing I think we have to take away from what you say, and I don't know how best to say this, but you know, we spend an awful lot of time talking about what is, and not a lot of time talking about what could be. And I'm going to frame this even in a Medicaid discussion. You know, Medicaid's a lousy way to fund a lot of our services. You know that. It's because it has all sorts of ridiculous restrictions on it because it wasn't intended to do what it does. Now, I'm not saying we're going to stop using Medicaid to do it because it's a funding stream you have to have. But honestly, we have to be bolder about what our initiatives are and what we're thinking about and how to do things. We can't keep recycling the same ideas because it is not sustainable in anybody's world to do that. And frankly, most of it isn't working the way we want it to work anyway. So we ought to unleash our creativity in a different way and begin to think. You know, outside the box thing is so trite and used, but we ought to be able to think about things in very different ways. I'm watching Allison walk around with her iPad as a camera, right? But I want you to think about that just for 1 second. Is that, you know, so 2 years ago, if you saw somebody walking around with something like that, taking pictures, you would wonder about why they were doing that, right? Nobody bats an eye anymore because of the change in technology. We haven't touched the surface on what technology changes can do for supports for people with disabilities. We don't think about it differently. We think about most everything the way we've done for the past 30 years. And we really need to rethink most everything we do and begin to engage that in the new system going forward. So part of encourage you is that not only stand up and say, you know, what you don't want to see in the system as it changes, but begin to talk about, you know, the bold ideas that will change what we do forever. And I think that's sort of the message I take from you, is that there's absolutely no reason in the world why we can't figure out how to support people, continue to have the needed supports they do at the graduated pace as they go to work, so people are encouraged to make more money and to reach their dreams and employment. That's what you're saying, I know. Yes, sir. I don't know where we are over here. Sorry.
Hello, Dave.
Hi again.
My name is Curtis Taylor, and I'm a representative of the substance use disorder recovery community on the Alliance CFAC. And I'll go ahead and give you another gold star, a pat on the back. When you first took your position, you committed to us to stay engaged with us, to have conversations, relaying information to us, and answering our questions. And from what I've seen, you stayed committed to that. So I definitely pat you on the back for that. In my world, I deal with a lot of people's first step towards the recovery process is admitted into a detox unit and an inpatient treatment center. And in Wake County, in the Alliance catchment area, right now, it is extremely difficult for a person to get into any detox whatsoever, especially if their drug of choice was not alcohol. The crack users and things of that nature are almost always going to be denied, to the point where some people are actually having to go out to the local corner store, purchase a pint of wine, go back to the parking lot of that local treatment center, drink the wine, and then walk back in the door and ask for help. Realizing that treatment on demand is one of the principles of effective treatment, and that's such a tiny window of hope and opportunity when that addicted individual does reach out for help in that small moment of clarity. And I just want to make sure that in all the planning process, that when we talk about treating that whole person, so to speak, that we don't make it so difficult for that addicted individual to actually receive some help and start that process. Brain chemistry takes a long time. That neuroplasticity process takes a long time. You know, the research says at least 3 months for a person to even begin to get back to normal. Right now, inpatient treatment in Wake County is 7 days, 9 if you're lucky. And that's only if you're lucky enough to get into that detox in the first place. The second thing I want to talk about is where a person goes in that transition from an inpatient treatment center, if they're so fortunate to get in one, where they can go. And safe and sober, affordable housing, and the fact that in the grand scheme of things, that hierarchy of needs, so to speak, housing is essential. And I know the Department of Health and Human Services doesn't necessarily do housing, but for that individual to get a small amount of money or financial assistance to even get out of treatment and move into an Oxford house or another type of recovery home for that matter would be so effective. It would save so much money because you're giving that person a fighting chance at success. Treatment's not long enough as it is, so that person is still detoxing, if you will, even after they do treatment. They have to have time to look for a job and get their brain back together and get grounded again. And so I'm just wondering is there any plans across the state to try to encourage the MCOs in their catchment areas to set some money aside for those recovering individuals who are graduating from treatment, or even coming off the street for that matter, but those who are fighting for their lives?
You and I have had a couple conversations at different places about that, and I'm embarrassed to say is that although we continue to talk about it internally, we haven't made significant strides yet in that effort, but we're not backing away. What I will say to you is that, if it doesn't do anything other than maybe give a little hope that we will do something here. As Governor McCrory, out of all of the areas that we deal with that he speaks about, substance abuse is the one he has is real passionate about. I don't know that he knows details, I'll say that, and why would he, right? But he has this absolute undying belief that if we don't address the issue around substance abuse around the state, that we are failing as an administration, and he will see that as a failure. So there's been a constant push from him to the secretary, and I'll say that a couple of times I've been in meetings with him, is that it's something he brings up with me, and every meeting with the secretary does. So we are, again, internally looking at how do we use resources in the right way. You know that, frankly, the biggest resource we have is the substance abuse block grant, which is not a huge amount of money. That there are certainly state dollars that LMCOs have, but honestly, that amount of money is limited in terms of their ability to move it around. I think what we have to do is begin to talk about how do we get the best bang for that dollar as we're going forward right now as we look at extending the available resources we have. So we have to have more of this kind of detailed conversation and probably a smaller group to do it. But I appreciate you not forgetting to bring it up and being a strong advocate about it.
Yes, sir.
Jason, I want to be mindful of your time. How much longer?
How about 10 more minutes? Is that good?
You can have as much as you want. I just don't want you to be late and get too frequently.
My question is there any news on the expansion of the utilization of peer support specialists? Because I see that as cost-effective, usually not more than 15 hours a week of support, and it doesn't involve potential mixed interest type problems.
You may have gotten me at a level of detail I'm not sure about. So is there some reason why are we limiting the expansion of peer support in some way?
I don't know that it's limited. I know that I think consumers have been frustrated that it hasn't grown in the last few years more than it has, and I don't know exactly what the current situation is across the state.
I'll go back and we'll spend some time internally looking at that. What may be the case is that there are a lot of people that have become certified as peer support specialists, and there may not be enough jobs right now for those individuals. And that may be because of a lack of sophistication or aggressiveness on providers. It may be because it's balancing at the right time. What I'd say is that we'll take a look at it, but I think, I don't know the answer. How's that? We'll take a look at it.
That's actually an absolutely wonderful segue to my question.
I'm not sure I'm happy about that.
You're probably not. Okay, so peer support currently in the state is not available to anyone without Medicaid. Now, the majority of the people in this state, or the majority of people, period, that have substance abuse issues don't have Medicaid. One of the most effective forms of treatment is a 12-step program. I think we can all agree upon this. So if you take a 12-step program and you look at it, one of the core components of a 12-step program is a sponsor. What is a sponsor? Sponsor is a peer support specialist. Why do we not have peer support specialists available for state funds? We only have it available for Medicaid funds, and it is grossly underutilized. There is so much good work that can be done, and I know this for a fact because I am a certified peer support specialist, and I have been fortunate enough to work with people that have substance abuse issues, and I've seen the growth that they've had. But I've only been able to touch the hands of a few of them because my hands were tied because I could not work with the ones that did not have Medicaid. And the majority of the substance abuse people in our communities do not have Medicaid.
I don't know the answer, but let me, in the same vein in the commitment of this, I think there has to be a, probably in a different forum, we have to have a more robust conversation about how we use peer support, what are the funding streams, and the matching between what jobs are available and the number of people are certified. But what we'll do is we'll make the commitment, and it probably will be after the first of the year, is to bring a group together to have that conversation. But I'll say this: I think it needs to be a smaller group because you need to have initially to start talking about it, and then we'll. But we won't leave it here. Okay, so we'll do that.
Hello, my name is Diane Dixon, and my question is way out there. I would like to know why Congress and the House of Representatives will not take a cut in pay to help the people in their community, and then why they will not change the term years for the people that are in the Congress and the House of Representatives. Most of them die there. So I was just like, and then they get paid after they retire. So that's a lot of money. So I know you may not have an answer to that. But I'm asking you, can you find somebody to ask that question to, and to get them involved in starting to trickle down some of the money that they make down to the people that need it, and down to Medicaid to help us out?
So I think you're absolutely right. I do not have an answer to that. And I would say I think the people that have the answer probably wouldn't answer the question. But you know, that is an obviously question, frankly, for Congress and the U.S. Senate in terms of them, and maybe the place to start is David, where whoever your congressional representatives might be the right place to start.
Hi, Dave. We were on work groups together a few years ago. I'm Dee Smith. I'm a clinical social worker. I used to work in the Department of Psychiatry, but I'm now at the School of Social Work. And as a social work practitioner, case management was an essential part of my practice. I specialized in working with people with schizophrenia for 20 years, across the life course, from the onset of the illness, which often occurs in early adolescence, at a time when people don't have Medicaid. And I've worked with people who have died from lung cancer, people who have schizophrenia. So much of what I've done involves what we used to call case management. I don't practice anymore. I'm moved into a teaching role. I've got a couple of questions. One is that on the mental health side, we do, and we rely on Medicaid to fund things, but there are many, many people with severe mental illness who don't qualify for Medicaid. I'm going to give you one example of a woman that I worked with 2 years ago who came to me. She was in her late 40s. She had had a late onset psychosis. She had worked professionally for many years. Her last working salary, she made $100,000 a year. But she had developed psychosis, and in the aftermath of that, lost everything. She lost her job, she lost her home, she lost her marriage, she gave away all of her belongings, and she was psychotic and homeless for 14 months, wandering the country. She showed up in my clinic for an assessment, referred for an ACT team, but she wasn't qualified. She couldn't get an ACT team because she didn't have Medicaid. I put many hours in working with her, finding her housing. She did get disability benefits because somewhere along the way in her travels, someone had helped her apply for benefits. But my question to you is, in a mental health system that is supposed to focus on people with severe mental illness, we completely miss people with emerging psychotic disorders, both in adolescence and in young adulthood, and at any time in life, because they don't have Medicaid. So what do we do about that? That's one question. And then I want to add one comment. I had sort of fought a long, hard battle to have meaningful case management that was provided by people who clinically knew something, because when you're working with people with psychotic disorders, particularly when they are having a difficult time in their lives, they don't need to be in the hospital, but sometimes they do need some intensive support. So what do we do about that? So the thing that I wanted to follow up with a comment is that I have a current project that's funded by the Kate V. Reynolds Charitable Trust, working with people who are mentally ill and homeless. And here in Orange County, we have people with untreated psychosis living in the woods. We have people with complex trauma living in abandoned houses. We have people who are dying on the streets with significant addiction, histories of mental illness, and all sorts of things. We're not serving a lot of people that need services. And I don't know, what do we do about that? Medicaid is not the only thing that is going to be able to take care of these things. So I want you to understand, too, that there are some things that work that maybe you're not hearing about. Critical time intervention is the model that I'm using. It's designed, it's an intensive case management model. It actually combines using a clinician leading the team, but it has a place for peer support specialists as well, has them working together. It's something that's a lot cheaper than hospitals and emergency rooms. It does have the ability to keep people out of crisis and to get them, to help them put things in life, put things together that will help them be sustained over the long term. And I hope we get to talk more, because it's been a while since I've seen you.
Clearly, we need everybody. We need to talk more on an individual basis. You can obviously call, email, right, we'll set up a time. We don't have an answer to the first question. We know that there are a significant number of people that without state service dollars, then they're not going to get served. That Medicaid is not the answer for everybody. It's not the answer for everybody in the IDD side, certainly not in substance abuse, and certainly not in mental health either. So we have to have and continue to have the support of the General Assembly, to have state appropriated funds available for those services. We probably can find more efficient ways to use that. I confessed early on that our division made it very difficult for LME-MCOs to draw down money. We're working through that as best we can so that all the money gets used as the General Assembly appropriates. We should never leave a dime unspent of that money. So we can do that. We can be more efficient. We can certainly reduce some of the regulatory burden that will allow that to go further at that level. We can look at administrative costs. And then we have to determine what is that, what is the General Assembly willing to put into a system, and that is really a big community question in terms of state dollars. But there is absolutely no doubt that we have a need for state-funded money in the system. I will say is that critical time intervention is one of those things we've identified in the crisis plan as a practice that we want to test more, we want to see more. And so Hopefully, we'll have good news about that coming in the second half of the fiscal year, about some things that we think will work as we go forward to see that. Because it is part of that idea that if we do the right community-based services, we can avoid crisis for so many people, and it's obviously a much better treatment for individuals. It creates better lives, and it's better for the state in terms of the cost and efficiency of it. Okay, so one more question, and then I'm going to run. I do have to go, and I think you want me to go in one, so.
I have a quick comment about the passion that you say he has for substance abuse services, and piggybacking on what he's saying, is that these are people struggling for their lives, and if he could consider what the criminalization of these people, the impact of that, if just the struggle is bad enough, and then when you criminalize their behavior, that makes it impossible to recover.
It's a great comment, and I think maybe it's a way to kind of close it. Part of what we recognize in that crisis issue, part of what we recognize in everything else we're doing is that DHHS, Division of Mental Health, or Median Substance Abuse, or Medicaid cannot be the only answer. There are a host of other agencies, community organizations, other people that are engaged and involved, and we have to make sure that we're coordinated and committed to those efforts. But we can't stop at the walls of what our department does. We have to look at the entire picture, because if not, we're not going to address the full needs. I should have done this when Lori sent up. This is a great example of a community project. I know that Lori was in the early stages. It probably was the catalyst for us beginning. And it didn't start because some agency said, let's do it. It started because a group of committed families wanted to see something happen differently. And I think we have to encourage that, and we have to support that, and we have to look across all of the spectrum of the services and community organizations that are out there and bring people together to create solutions rather than just rely on one. But it's a great point. And I apologize, I have to leave, and it wasn't the intention early. I know it's shorter than we had originally planned. But what I want to commit to is that if we can, think about doing this on a regular basis, I think it's a great opportunity to have a forum, not just about this, but other things, and also at the other CFAC. And thank you for your time. It's so much nicer.
We made little survival kits that you all can get on your way out. We're not ready to do just yet, that we'd like to present one today. I would like to recognize two people in our audience, and one person I actually put on the spot earlier. Sue Guy is the state CFAC chair, and I asked her to give us a brief summary on what State CFAC is doing. I'd also like to recognize Mark Jakes. He is the co-chair of State CFAC, and he actually is
She said put me on the spot. I'd like to thank Dave for opening for me. He's talking in his good lecture. I'm very honored to be a part of this. I'm here really in my role as Eastport CFAC, but I can't take the State CFAC hat off. And I do want you to know, after listening to some of your comments, meeting some of you, and hearing some of your questions, I've made a list of your names because I consider you, some of you may have already served on State CFAC, but when there are openings, don't be surprised if you get a call from us and say you're interested, because we need this passion at that level too. I did want to ask, how many of you have been on one of our conference calls, local CFAC, State CFAC? Pretty good, pretty good. We also have the chair of that interface committee, Gladys Christian, sitting over here. Gladys, coordinating those calls every other month, and for those who haven't been a part of it, this is an opportunity, and one of the things that we at State CFAC does as part of our statutory promise is that we are here for you to use as a tool. If there's some questions or information you need, you can contact us. We'll be glad to share it. If there's information that we get a scoop on, we want to share it back. And that's one of the reasons for these calls. Glad this gives an opportunity for at least 2 CFACs every time to just talk about what's going on. And for those in other CFACs to kind of build on that, we've shared some information that something's working really well in one can be shared with another. It's just a really good opportunity to do that. And then we address different topics that pop up, like we took care of the budget, our opinion of it anyway, and some of the other things that come up. So that's a real good tool to use. Remember that we're here to help you, that we're totally separate, totally independent, we do understand that, but we are here to help in any way. Do any of you have a question about state CFAC? Remember, I got some of your names. Thank you.
Okay, guys, we've got a few more minutes. If there's any comments or questions that you would like to say now, we can make sure that we get that to Dave.
Actually, things in here, right?
Or if you'd like to write them down, there's a basket Anna can collect. But if there are any comments you would like to make right now for everyone to hear, Dan still got the microphone. And I think you have a comment.
I had a couple of different questions. First one, the 5-person committee, I wanted to find out whether any of those 5 people were consumers or family members, or if they're just professionals.
They are not.
I didn't think so. The second one, he had mentioned that, and I'm almost quoting verbatim, that self-direction was the way to go. But then he turned around and said, one-on-one 24/7 care is not sustainable. They're almost contradictory to one another, so we need to get clarification on that. And then the third one was, we need a time frame of when to expect what services we're looking at now are going to get cut or expanded or whatever. We need some type of time frame so we can plan as parents and as consumers to deal with what we need to deal with in our everyday life.
Amen. I totally agree. Being proactive is just that way to go. And those are definitely things that we will make sure Dave gets.
You know what? I'd like to make a 6-person committee, and I want to be on it. And I'm serious about that.
The committee Dave was talking about, there are a couple of handouts over at the desk. There were a couple. But once the meeting, I think there's a meeting tomorrow, they will continue to meet. And like Dave said, they will be open for public comment, just not the meeting tomorrow. But future meetings will be open for comment. And I really encourage all of us in this room to attend. If you feel that strongly, and part of our job are to advocate, we need to be there. You know, the state is empowering us as CFAC members. We need to take that and go and speak and share our thoughts and feelings. I think that's what's gotten us to where we are now. Like Dave said, the future, it might not be CFAC, it might be another name, it might look different, but family and consumer involvement would definitely be a part of the system. And I think that he truly is committed to that. But we can't stop. We have to continue to make sure our voices are heard. Do you want to add anything?
No, we just really appreciate all the advocacy you do and you showing up here today to speak with Dave Richards and ask him some very good questions. It really helps to clarify it. And we, like I said, we really want you to continue to do that, both in your local areas for your MCOs and and statewide, because that's really going to make the difference, is to work with the agency, with the state agencies, but also with your legislatures and your home communities to make sure they understand and to get them to vote for things that will be very helpful for the mental health, substance, and disability services in the future.
One of the things I want you all to really look at, Dave said he would like meetings like this to continue. We had 2. We We have the one that CenterPoint did. We have this one. I would like to encourage another MCO CFAC to schedule another one maybe 3 months from now, because at that point the regions are going to be separated. There might be more information. We want this information yesterday. We can't get it that quick. But if we continue to have these meeting schedules, maybe we'll have the most current up-to-date information. So I really would encourage another group to step forward and get that meeting started, get it set, because Dave will come. He will come. If there's nothing else, I'd like to thank you, and hopefully we'll see each other again in the future. I don't think anybody will mind leaving a few minutes early. Please take a survival kit.
Adam, did you want to say anything about the survival kits before you leave, since you're done though? There's a chance to talk.
I was just going to say one thing, is that if you have questions, we're going to be taking those. So don't think that if you still have a question that it cannot be answered, and we will move it forward. And so there'll be a basket, and then also before you leave, please do take a CFAC survival kit. And I think it's our way to say thank you for being here. And I urge an MCO, CFAC to please step up and be the next host. We look forward to coming to your area. Bye.